A very good day to you, dear colleagues. My name is Andrei Vavensky. I work as a consultant anesthetist in the southwest of England. Today, my topic is capnography, more than just CO2 monitoring, interpreting waveforms in clinical situations. Why continuous capnography is so important? I referred you to the fourth National Audit Project, NAP4, which lots of you might have heard about. It is called Major Complications of Airway Management in the United Kingdom, a prospective study by the Royal College of Anaesthetists and Difficult Airway Society, investigating major complications of airway management in the UK. It found that airway complications occurred in the intensive care unit and the emergency department more frequently than in theatres, and that airway events in these areas were much more likely to lead to permanent harm or death. In more than 70% of the deaths in these areas, failure to use capnography in patients dependent on an artificial airway was reported to be a contributing factor. Following the publication of NAP4 in 2011, UK and European guidelines have been modified, with the Association of Anaesthetists of Great Britain and Ireland issuing safety statement in 2011. This stated that continuous capnography should be used in all anesthetized patients regardless of the airway device used or the location of patient, and should be employed in all patients receiving advanced life support. So what is capnography or capnometry? Capnometry is the measurement of the CO2, carbon dioxide, in a sample of gas. Capnography is the continuous monitoring of the concentration of partial pressure of CO2 in respiratory gases. This is represented in a graphical form with time on the x-axis and expired partial pressure of CO2 in the y-axis. The result is capnography trace or waveform. The end tidal CO2 is the maximum partial pressure or concentration of CO2 in the respiratory gases at the end of the exhaled breath. A capnometry monitor displays the end tidal CO2 value alone, whereas a capnography monitor displays end tidal CO2 value plus a continuous capnography waveforms. A capnography trace, what can we derive from a normal capnography trace? A capnography trace allows two pieces of information to be displayed: end tidal CO2 value and a continuous waveform. The end tidal CO2 is a non-invasive estimate of the CO2 concentration or partial pressure in the arterial blood, with end tidal CO2 being about 0.5 to 0.8 kilopascals lower than the PaCO2. So PCO2 in the arterial blood in a healthy patient with a normal lungs. This difference is increased if there is a mismatch between ventilation and perfusion of the lungs, as seen in patients, for example, with lung diseases, pulmonary emboli caused by thrombus, air, or fat, low cardiac output states, and hypertension. On the screen, you can see a normal capnographic trace with a few markings there. There is A, B, C, D, and E points, where AB line represents baseline, BC expiratory upstroke, CD expiratory plateau, D is where we measure end tidal concentration, and DE is inspiration. Most capnographs measure CO2 via infrared CO2 detectors called Luft detectors, which was first introduced by Carl Luft in 1943. Use of their technology in the medical settings began in 1950s. Because of the data from the detectors has to be amplified, calculated, and converted into signals for display and graphing, early capnographs were large multi-piece machines. The Goddard detector head, or analyzer pictured here on the left, was the smallest part of the Goddard capnograph. The patient exhaled air was pumped from the breathing tube to the detector head, where the infrared Luft detectors measured the CO2. Via a cord plugged into the socket on the top of the detector head, data was sent to the piece of the capnograph that housed the computer parts and pump. This piece of the apparatus was about 3.5 feet tall and 2.3 feet wide. On this sat a graphing printer that produced the capnogram. Today's detectors measure only inches inside, and capnographs are often portable. Other monitoring devices have also considerably reduced in size, and often the capnogram is only one function in a monitor that also displays vital signals, electrocardiogram, oxygen saturation, temperature, and so on and so forth. Let's look inside of the normal capnographic machine. The heart of the capnograph is the infrared gas analyzer. The infrared analyzer can measure many gases and works on the basis that any gas which contains two or more different atoms in the molecule will absorb infrared radiation. This is also known as the Luft principle. Each gas absorbs radiation at a particular wavelength, such as 4.26 nanometers for carbon dioxide. In the infrared analyzer, infrared radiation is emitted by a hot wire here on the left part of the screen, and the frequency of the infrared required to measure concentration of a particular gas is obtained by passing the radiation through a filter. The infrared radiation then passes through a crystal window into the sample chamber that contains the gas to be analyzed. A gas window cannot be used as glass absorbs infrared radiation. So we use crystal window instead. Within the sample chamber, the gas present will absorb the infrared radiation. The amount of radiation absorbed depends upon the concentration of gas within the chamber. The higher the concentration of gas within the sample chamber, the more infrared radiation will be absorbed. The radiation passes through another crystal window on the other side and falls onto the photo detector. The detector output is processed electronically to give a reading of gas concentration. This follows the Beer-Lambert law, which describes the relationship between concentration of the measured substance and the path length of infrared beam traveled. Let's talk about the types of infrared capnograms. There are two types. The most common type is the side stream type, where the sample gas is drawn into the main respiratory flow through a side port via a narrow tube to the sample cuvette. The flow rates vary between 50 and 500 mils per minute. Following CO2 measurement, the gas is either returned into the expiratory limb of the breathing circuit of particular relevance, that is to low flow anesthesia, or gas can be scavenged. So if you're using low flows like 500, this will interfere with your low flow technique, this side stream capnograph. Advantages is generally more convenient than the mainstream monitors. The patient attachment is less bulky and more robust. Disadvantages: without elaborate water traps and filters to remove the water vapor, the measured value of the end-tidal CO2 would be invalid. A suction pump transfers the sample from the site of sampling to the measurement chamber. This sampling rate can in itself introduce error. The response type of these instruments tends to be longer than the mainstream analyzers. In the mainstream capnograph, the measuring head inserts into the breathing or ventilator circuit so that it carries the main gas flow. The capnograph head acts as the sampling chamber, and it transilluminates by illuminated by infrared light through the side windows. Advantages: the position of the probe makes removal of the sample of gas from the breathing circuit unnecessary. The system is far less complicated, no suction pump required, for example. The errors due to the gas sampling are eliminated. Response times are significantly less than with the side stream type. You may say that the mainstream capnography is obsolete and is never used these days. But on this picture, you can see a very modern Yvonne ventilator with flow-controlled and jet ventilation modes that, unlike any other jet ventilators, allows to measure CO2 with the use of mainstream capnography, as obviously using sidestream capnography would be impossible due to a high sample flow rate for the effective use of jet ventilation. So here it is in the yellow circle. You can see the mainstream capnograph of this very modern, very, very interesting ventilator, but that is the topic for another presentation. Modern capnographs exist essentially as a small module that became part of the monitor next to few other modules that measure other parameters like pulse oximetry, blood pressure, neuromuscular transmission, ECG, bispectral index analysis, and so on and so forth. And that is the size of the module. It's very, very small. You do not need to intubate the patient to use capnography. Many devices do exist on the market these days. This one is called Capnomask. It provides oxygen supply and contains the CO2 sampling line with the filter to capture the moisture of the machine end of the line. It can be used for cases, for example, sedation in many procedures like upper GI endoscopy, colonoscopy, operations under neuraxial anesthesia with or without sedation. Now let's talk about the normal capnometry waveform. It could be subdivided into three phases. Phase 1, the blue line here. This is the inspiratory base and reflects the inspired gas, which has only a minuscule amount of the CO2. The lack of CO2 detected in this phase results in a flat waveform. Phase 2, the pink line, at the beginning of expiration, exhaled CO2 rapidly rises, and so does the slope of the capnogram. CO2 travels from the alveoli through the bronchi and trachea, the conductive airways, where gas is present but cannot be exchanged, anatomical dead space that is. The speed at which the CO2 is exhaled determines the slope of this part of the curve. And then we have phase 3, the red line, and red line is the alveolar plateau. The gently sloping plateau represents late expiration, when alveolar gas rich in CO2 is detected. The angle between phase 2 and phase 3 is called the alpha angle, which this one, alpha angle, which represents the change from airway to alveolar gas. The value of the end of the slope is called the end tidal CO2 here. The maximum aspired CO2 concentration. The end tidal CO2 is the numeric value on the monitor and is normally 4.5 to 6 kilopascal or 35 to 45 millimeters of mercury. And phase 4, also known as phase 0, and the yellow line is when CO2 values drop sharply as inspiration begins. To reiterate the message from the previous slide, let's repeat a few important points on the normal capnometry trace. The first one is at the end of inspiration, CO2 trace should reach 0. Then we have transitional part of the curve. This represents mixing of dead space and alveolar gases. Alpha angle we spoke about represents change from airway gas to alveolar gas. And then the plateau part of the trace, alveolar part of the curve, represents the plateau average alveolar CO2 concentration. This is the point where we take end tidal CO2 concentration. This represents the maximum alveolar CO2 concentration. This is the number that will be displayed on the screen. Okay. What are the applications of capnography? There are many: confirmation of the tracheal intubation, monitoring patients with raised intracranial pressure, monitoring response to the treatment of bronchospasm, estimating of cardiac output, and use during cardiac arrest. And particularly for cardiac arrest, the confirmation of the tube that is inside is important. Monitoring ventilation rate during CPR and avoiding hyperventilation, assessing adequacy of chest compression during CPR, identifying return of the spontaneous circulation, and it can also be used as a prognostication during the CPR. There are factors that can cause elevation or drop in end tidal CO2. They are listed here on the left and on the right side of the table. So on the left, there are causes of elevated end tidal CO2, and on the right, causes of decreased CO2. And they could be subdivided into metabolism, respiratory system, circulatory system, or indeed medications. And among the medications that will elevate the CO2 is, of course, administration of bicarbonate. And also shivering, hypothermia, pain, respiratory insufficiency, COPD, and so forth. So things like bronchospasm, mucus plugging, metabolic acidosis, hypothermia will decrease the CO2, as well as hypotension, hypovolemia, cardiac arrest, and pulmonary embolism, of course. What are the abnormal capnography waveforms? It could be a waveform during esophageal intubation. We'll talk about all of them in turn. And the bronchial intubation, bronchospasm, mechanical airway obstruction, reversal of the alveolar slope in emphysema, cardiac oscillations, as well as coronary cleft, CO2 rebreathing due to the exhausted CO2 absorber, low end tidal CO2 in hypothermia, a high peak of the alveolar phase in poorly compliant lungs, and of course, malignant hyperparexia. Right, let's have a look what happens during the esophageal intubation. Though initially there is some CO2 returning through the tube, one finds with subsequent breaths the end tidal graph is lower and lower and lower, and then the patient is getting more and more hypoxic. The abrupt straight line usually represents circuit disconnection in one or another part of the circuit. Other reasons for flat trace is ventilator disconnection, like I mentioned, airway obstruction. For example, the patient suddenly bites down on the tube, and tidal endotracheal tube perforation, capnograph disconnection or obstruction, water droplet contamination of capnography module, apnea test in the brain dead patient, or cardiac respiratory arrest. It would probably be important to qualify that last point with this. Will be probably important to explain a little bit more about the cardiac respiratory arrest. The entitled CO2 waveform in cardiac arrest would only be flat if the heart has stopped and you are not doing anything about it. Under normal circumstances, the patient would be having CPR, which means there would be some decreased cardiac output from the cardiac compressions, and the waveform would not be perfectly flat, like on the left side of this graph. Even in the absence of CPR, there would likely to be some end tidal CO2 returning to the sensor, keeping the trace somewhat above zero. In other words, if you are doing CPR and the end tidal CO2 trace has flattened after intubation, the only rational explanation is that the endotracheal tube is in the wrong place. In 2022, PUMA, Project for Universal Management of Airways, released these guidelines for preventing unrecognized esophageal intubation, together with few international airway societies from Australia, UK, USA, New Zealand, Switzerland, India, Ireland, South Africa, and Italy. And they came up with 11 different key recommendations, and I shall leave it to you to read all of them in more details, but draw your attention to item 6 that says, the default response to the failure to satisfy the criteria of sustained exhaled carbon dioxide should be to remove the endotracheal tube and attempt to ventilate using face mask or supraglottic airway device. This caught many people who said, yes, I saw the tube going down the trachea. It's in the right hole. I'm adamant. It won't take you long to reintubate the patient, but it will exclude the esophageal placement of the endotracheal tube. And the bronchial intubation, let's have a look at several different capnography traces patterns. This built waveform represents, BIFID, represents the differential ventilation of two lungs. Basically, as the endotracheal tube is positioned mainly in the right main bronchus, the airflow through the right lung is the best. And the right-sided gas forms the first, brisk and steep, part of the waveform. Afterwards, one notices that there is a secondary transitional phase, which is the gas from the left lung escaping slowly up into the endotracheal tube. Of course, if the left lung was completely isolated, i.e., you have the cup inflated in such a way that it blocks it totally, you would not see this waveform. This only happens if the tube is somewhat leaning more towards the right side, the right bronchus, main bronchus. This is the classical sawtooth slope of the asthmatic patient. As the airway obstruction in the bronchi worsens, so the slope of the transitional phase becomes more gradual. Note that there is no distinctive alpha angle. This means that the bronchial constriction is so severe that the dead space has not finished emptying by the time the next inspiration comes along. Thus, as bronchospasm is relieved, the alpha angle will again appear. This is the representative trace of a mechanical airway obstruction. In the case of the airway obstruction by some sort of fixed mechanical obstacle, for example, big gross tumor, the inspiratory flow will also be affected. Thus, both the transitional phase and the inspiratory phase will be affected. And most strikingly, the inspiratory phase slope will become less steep, indicating that the obstruction cannot be overcome even by powerful ventilator turbine. This pattern can be generated without any pathology by the intensivist who sets the inspiratory rate time to be prolonged by whatever reason. In emphysema, the alveolar slope will be reversed. The gas exchange surface is so poor and the compliance of the lungs is so abnormally increased that the alveolar gas exchanges very rapidly. Thus, the part of the curve which represents arterial CO2 in the early peak, not at the end tidal value. Thereafter, gas in the ventilated tubing diffuses backwards into the patient. There is an equilibrium between the higher CO2 inside the patient and the lower CO2 in the ventilator circuit, with the resulting gradual drop of the total CO2 concentration in the capnograph adjacent tubing. This waveform represents the pulsation of the extra-large heart transmitted to the lung parenchyma. The resulting changes in the lung volume are enough to move a small amount of gas back and forth, creating ventilation of some sort. In some circumstances, this may be feature of cardiomegaly. The curare cleft seen in the alveolar plateau is actually a patient making an attempt to breathe. With their feeble inspiratory effort, some fresh gas sucked from the ventilator tubing and past the capnometer, generating this pattern. It is most frequently seen in anesthetic machines where there is a constant flow of fresh gas across the circuit. This curare cleft comes from the patient inhaling in between ventilator-delivered breaths and is usually a sign of asynchronous breathing. However, in the post-arrest scenario, it is a positive prognostic sign as your patient is breathing spontaneously. Another feature unique to anesthesia, this is if the CO2 absorbing line canister is saturated, the circuit becomes inundated with expired CO2 and the baseline gradually increases. In the ICU, such a thing is unknown, and it would be very surprising to see such rising CO2 baseline. So all you need to do is to change the soda lime canister or increase the flow rates. If you're using lower flow rates, then anything above 6 liters per minute will flush the extra CO2 out of the circuit. Obviously, if you're using inhalation anesthesia, this will be very, very wasteful. This is the high peak of the airway phase in poor compliant lungs. And this pattern is called a pigtail capnogram. It is typically seen in poor lung compliance, but it can occur in pregnant women and obese patients. Essentially, the sudden peak of the pre-inspiratory expired CO2 is due to sudden airway closure. It occurs when a poorly compliant lung or a huge fat chest wall, for example, or a big pregnant belly, crushes the last few milliliters of CO2-rich gas from the alveoli before the collapse of the lung parenchyma also clears the small bronchi and puts an end to the escape of the gas. Let's talk a little bit more about the use of capnography during CPR. When ROSC, return of the spontaneous circulation, occurs, there will be a significant increase in end-tidal CO2. This increase represents drastic improvement in blood flow, which indicates circulation. So the return of a good CO2 trace means return of the cardiac output. So that's how capnography is used as a prognostication, well, first of all, as a indication that you're doing a good CPR, and then as a and then as a sign of the return of the spontaneous circulation. Capnography is a surrogate tool for assessing cardiac output, and examples include sudden drop in the end-tidal CO2 that represents a reduction in pulmonary blood flow that could be due to pulmonary embolism or cardiac output. Gradual decrease of end-tidal CO2 represents slow decrease in cardiac output, and vice versa. In B, we already spoke about esophageal intubation. That is again a gradual decrease in CO2 value. And in C, diagram C at the bottom of the slide is a typical trace of the fast rise of end-tidal CO2, classically representing the acute MH, malignant hyperpyrexia. If you see this pattern, take the temperature if you're not monitoring the temperature constantly, and be very suspicious if your temperature goes up by 1 degree in an hour. This is very suspicious for developing malignant hyperpyrexia. This is the learning tool I wanted to draw your attention to. It's called HATS. And if you see a top hat type capnograph, this is good, clear, unobstructed airway. If you see something called side hat or ascot hat, like ladies wearing in Ascot for royal horse races, it is partially obstructive airway. If it's a party hat, it's bad because it got significant leak. And no hat, very bad. Your tube is in the wrong place. We're coming to the end, and I would like to draw some conclusions for you. So capnography can be used in both intubated and non-intubated patients. Uses of capnography are wide-ranging and not limited to monitoring of the airway, like we spoke about. Capnography should be used in all patients in the perioperative setting. And you can see here, this is a device that can deliver oxygen through a mouthpiece and also take the CO2 sampling during, for example, upper GI endoscopy. Very, very useful device. More conclusions: no trace, wrong place. No, if there is no trace, take your tube out, re-intubate your patient. Remember that the hyperventilation occurs before hypoxia. Hypoxia is later than hyperventilation. Be able to interpret the normal waveform, and pattern recognition can help identify abnormal forms. Now, I have used a few literature sources, and here's some on this slide for you that you can look up later. I thank you for your attention. We spoke about capnography more than just CO2 monitoring, interpreting waveforms in critical situation. My name is Andrei Vavinsky. I'm a consultant at Torbay Hospital. I also would like to draw your attention to this QR code, which if you scan from your screen will bring you to my YouTube channel,